So my name is Jason Purcell, and my current role is Director of Hospital Pharmacy here at Mercy Hospital in Lebanon, Missouri. Been in this role for about a year and a half. Prior to that, I was a pharmacy manager at one pharmacy or another for the last 20 of 24 years. So extensive background in management and people leading. And a few years ago, I started to wonder if that was all I would ever do. So I decided to do some reflection and ended up stepping down from my then leadership role and just being part-time and PRN and being a floater pharmacist. Went back to school and got a master's in healthcare administration and a certificate in public health, which led to this position. So really, really been enjoying the last couple of these last 18 months here at Mercy. It's been a great place to work. We talk a lot about finding meaning and purpose in your life, and sometimes you struggle to find that on a daily basis. And I can honestly say that here at Mercy, I don't struggle at all to find that. Every day I find a new reason to come to work and leave work fulfilled. Well, to understand why we have these current challenges, you really have to look at our history. When I was a manager from Walmart, not only did we have applicants from outside the store, we also had applicants from inside the store. Your typical supercenter might have 500 employees that you get to meet and greet over, your time working there. And so you really get the pick of the litter, so to speak. You find out, who might be a good fit for your establishment without actually having to hire them. And usually your store managers at a Walmart or a Walgreens, they also know who's going to be a good fit for your pharmacy, and they want their best people in the best positions. And so in the past, it wasn't really hard that challenging to find good technicians. But if we look at what's happened recently with the changes and challenges in healthcare, of course, we had the COVID-19 pandemic, which really gave the system a shock. And right around the time the vaccine was released, started to have this situation where folks were second guessing whether or not they wanted to be in their current roles. One economist even coined a term, the Great Resignation. And we saw, upwards of 30 to 40 to 50% of folks either leaving their role and transitioning to something else, or just saying, you know what, I don't want to work anymore. And so as a healthcare provider, you have to try to fill positions, and you're not getting the applications that, you once were getting 20 years, 10 years ago, or maybe not even 4 or 5 years ago. So it becomes even more challenging to replace those who have left. And the same is probably true today in retail pharmacy. Just talking to my colleagues, they're not getting the applications they once were. And then you're asking those folks to come in and work a entry-level position dealing with the public who's still got some anger issues and some resentment issues, on top of all the normal stress of a retail pharmacy customer, drugs being expensive, drugs not covered by your insurance, doctors not replying. Retail pharmacy is a stressful environment. It's not for everyone. So trying to find folks for those roles is increasingly challenging. I spoke to one of my Walgreens colleagues maybe about 30 days ago, and she told me that she's had 75% turnover in 1 year. Those struggles are real. And for healthcare in general, they're not going away.
What challenges are you facing in hiring as an HR leader?
We do have one thing that we didn't have at Walgreens, which is recruiters. And so we have folks that are actively helping us fill those roles. Here recently, I've taken on reaching out to some of my community colleges and work centers in the area to fill my most current position. I'm kind of fortunate at Lebanon. It's a tight-knit bunch. Everyone seems to get along and work well. So the fact that I actually have an opening is a little unusual, but that's what I've had to do recently. But outside of pharmacy, even in healthcare, um, we might have 2 or 3 nursing applicants um, for 6 or 8 positions. Um, and the more rural you get, the more the more challenging it is to bring those candidates in. We've had frank conversations with our administration about the challenges they've faced with nursing recruitment, with physician recruitment. About every 2 or 3 months during our admin huddles, they'll give us a summary of the doctors that they've interviewed, where they are on the, in the hiring process. The challenge usually isn't can we get applicants. The challenge is, can we get them to come to Lebanon? Can we get this doctor to come and look at our facility when they're used to working, at a big city clinic with all the newest equipment and the latest gear. And then aside from just the equipment issues you have, not a lot of doctors want to leave and work in rural Missouri. And you wouldn't even think of, a town like Springfield or Columbia as being rural. But, when you can compare it to living in St. Louis or the Minneapolises of the world, or they're not, it takes a very special applicant to be that person to move to a rural location. And then when you do get them hired, usually they're still under contract at their last facility. So you have to wait for them to be free to come. Our current hospitalist group, we actually hired last December. One of them started in July, one of them started in August. So even if you get them hired, it might be 6 to 8 months before they come and work in your facility.
What do you say to pharmacists in rural areas struggling to hire?
The challenge for pharmacists is sometimes we don't look outside our own environment. There's a pretty famous pharmacy term going around right now called "pizza is not working," where basically pharmacists are, very fed up with the working conditions they've been given. I think the biggest eye opener for me coming to Lebanon is understanding that pizza is not working for everybody. I mean, that's just not a catchphrase for pharmacy anymore. Nursing is stressed. EVS folks are stressed. Our supply folks, they feel the stress as well. And if you really think about what that message says, pizza is not working. Well, why do we order pizza? Because it's quick. It's usually the only food that gets delivered pre-COVID, before we had DoorDash. It's one of the very reliable things you could get food brought in. It's a quick way to show your team appreciation. But if the only way your team feels appreciation is on pizza day, then chances are you're going to have high turnover. So on top of all the other things pharmacists have to do between filling prescriptions, answering phones, running the counter, worrying about labor shortages, you also have to worry about whether or not you're going to get arrested for filling a controlled substance prescription. And that may be a little bit of hyperbole, but it can be challenging sometimes to look at a prescription and think to yourself, well, I got 30 seconds to look at this prescription and determine if it's legitimate. Because if I take any more time than that, I'm going to get backed up in my queue. And then there's going to be not just this customer that's upset, but then I got 10 more behind them. And so we're really caught in a catch-22. And each pharmacist that works and fills controlled substances is going to approach this a different way. But when you're truly afraid of government enforcement actions, to the point that in the case of one independent, where they're going to tell you, we'll fill it for you this month, but if you come back, we're not going to fill it for you again. I mean, your business model is not filling prescriptions. That's not a business model that's sustainable long term, unless you're so afraid of enforcement actions that you feel no other choice. But at the same time, if you look at some of these cases where pharmacists and pharmacies were cited by the board or cited by the DEA, it was for blatant disregard of red flags. Take the case of CVS in Florida. Uh, they decided, we're only going to fill 5 oxycodone prescriptions a day, and after that, no more. So they didn't look at the prescription itself. They didn't do any validation work. They just said our limit is 5. Well, is it 5 patients from Appalachia or is it 5 Florida patients? And so that blatant disregard in reviewing red flags led to some citations for their pharmacy, even after receiving warnings 2 years prior from the DEA about their practices. And of course, now most pharmacists are familiar with the term red flags. That term actually came from a court case in the Trinity prosecution. And I hear a lot of pushback from pharmacists saying, there's no law that says these are red flags and I have to evaluate red flags. Well, it is true that if you go looking in the Missouri Registrar or if you look in the FDA guideline books, you're not going to see any law that says red flags. So if you pull it up and you do a search and type in red flag, you're not going to find a law that specifically says you need to review these red flags. But we've had enough court cases now that have established that red flags do need to be reviewed, that it should be considered case law or more to the point, common law. And any pharmacist moving forward or a pharmacy that gets flagged for this, for blatant disregard of certain red flags, you really have to wonder if they've been paying attention the last 20 years. You're going to have one-offs, pharmacy, you're on vacation and the doctor gives you a week's supply to get you by and you take it with you to fill because your hometown pharmacy won't fill it early. But I think continuing to ignore red flags is only going to be problematic moving forward.
Tell us about the 340B program and how that impacts critical access hospitals and health systems.
So my first experience with 340B was when I worked a 4-day shift in South Central Missouri, and I came across a region where there was a lot of poverty, but some of these folks didn't qualify for Medicaid. And I noticed that they were getting prescriptions at a fairly reasonable price. And I inquired about this. And what I learned is that the intention of 340B is to bridge that gap between the folks who are very poor and need Medicaid assistance and those folks that do make a little bit of money but don't make enough for it to qualify to have a health plan. And with the way that the Affordable Care Act set up insurance plans, now we have a lot of folks that have insurance, but they have a $3,000 deductible. So the idea of having to spend $3,000 before you get to that $10 copay can be quite a burden to overcome. From the hospital side, obviously, we could talk forever about reimbursement rates from insurance companies. I know there's been a lot of articles written about Medicare Advantage plans doing a lot more denials than traditional Medicare. But hospitals like mine, like your critical access hospitals, like a Mercy Aurora or Mercy Cassville, these 25-bed hospitals who get just a little bit more reimbursement to keep their facility afloat. That's why they qualify for critical access. Having extra funds available through the use of 340B really can decide whether or not your hospital is going to be in business next year. And I think a lot of community members don't realize the value of that. I think a lot of our legislators don't see the value of that. When I went to speak to our legislators back in April about the value of 340B, and Missouri had a bill on the floor to require some transparency on the part of drug manufacturers. And the pushback I got from those legislators was that hospitals are taking these funds and building mega hospitals and building Taj Mahals, is what he called it. So, they're not seeing the unreimbursed care that our hospital gives. They're not seeing the patient assistance that we might give a patient by purchasing their prescription so that we don't have to worry about them paying for it at discharge. They're not looking at, well, we paid for your bus trip to Joplin so that you could go stay with your mom and get better for 10 days after being in the hospital. They're just looking at what they can see, which is, quite honestly, lobbyists for these insurance companies and drug manufacturers telling the legislators that hospitals are wasting that money. And so I think as hospitals, we have to do a better job of telling our story, telling these legislators, what are we doing with those funds? And when we can tell a better story, then folks will understand. One legislator told me if he scheduled a hearing about 340B or insurance issues, he wouldn't get anyone to show up that day.